doctor thing where you see if you can ask a question. And you know what? I've had a lot of people ask me questions on this program that they've said, "What about this?" And I'm like, I don't know about that.
That doesn't happen as often as you make it sound like it happens. You do know a
Occasionally,
lot.
yeah.
All right. So I think we got it.
Well, that kind of surprises me though, because this is my profession. I really love it. And so I'm always like researching and studying. Like, okay, today I had somebody come in today, and he's been going from doctor to doctor to doctor for the last year, because he started out with anxiety and he's had all these things. He's had psychiatrists. He's been given all these medications and all these things. Nobody stopped to figure out what his problem was.
Mm.
And he was 30 years old. He had high blood pressure. They just gave him a high blood pressure medication. Didn't say, what the heck? Why does a 30-year-old have high blood pressure? That doesn't make any sense. No, they just gave him a high blood pressure medication. Also, a bunch of tests. We're looking through all his tests and everything. His renin levels are really high, which means his kidneys aren't getting enough blood flow. So he's got a kidney problem, and they're just giving him a blood pressure medication. His kidneys are going to die. It's like, why not just like figure it out. And I get it. It takes a long time. So I have an hour to an hour and a half with every patient. Today I spent an hour and a half with this guy and went through everything and kind of narrowed it down to, we know what we're going to do now. Whereas if you only have 10 or 15 minutes, there's no way you could do that. No way. Or the average primary care physician, I had 4 minutes per patient. 4 minutes. Come in, say hi, what's your problem? Here's a drug, bye.
Wow. That's crazy. I haven't been in a traditional healthcare facility, I guess, in a while, so I haven't experienced that. But I guess in a while. But I'd be curious in the chat. Let us know how much time you spend with your doctor. When maybe you found out you have high blood pressure or you have type 2 diabetes, how much time did you get with your doctor? And it's not, necessarily their fault. They have to get through a lot of patients in a day and they're doing their best, hopefully. But I would be curious to know. Okay, let's do this. All right, we've got a bunch of questions. Looks like we already got Joe chiming in with some questions. I haven't even read them yet. I'm a little nervous, but here we go. All right, here we go. Diabetic myth or truth? Here we go. No one in my family has diabetes, so I won't get the disease.
Oh, that's a myth. Oh, that's a bad one. Because anybody can get diabetes type 2 by becoming insulin resistant. And there's a lot of reasons why that can happen. And some of them are genetic. So sometimes it runs in families, everyone in my family has diabetes, people that come in and say that. But I'm the one that doesn't have it. Why? I don't know. You didn't get that gene or whatever. So yes, there are genetic reasons for getting insulin resistance, for not using your sugar very well. If you look at certain, in the United States, certain indigenous American tribes have really high rates of diabetes, like I think the Pima Indians in Arizona, it's like 80% of all the people have diabetes. 80%. That's 8 out of 10 have diabetes. That's really high. And so clearly there's a genetic issue there. That's not just lifestyle. And then other people, they say, it's related to fat or whatever. And I'm sure we'll talk about that. But the answer is no. You could get type 2 diabetes just by not taking care of yourself. And it doesn't have to be genetic.
All right. I'm going to sneak in one of Joe's questions here. Let's see. Ooh, a couple of them. Okay, I don't even know about some of this. Okay. Actually, why don't you ask it, Joe?
Okay. Just off the top of my head, what's your opinion on the potential use of CRISPR gene editing to cure type 2 diabetes by altering insulin signaling pathways? Do you think it will be safe and widely available within our lifetime?
Did you ask AI this?
Ow.
Okay, so the CRISPR genes, that's a way of inserting genes. So you can put them into a virus, for example, and get the virus to infect that gene to put in a normal insulin, for example, or a normal gene where people have genetic problems. You know what? It's very early to think about, and there's so many potential problems with it that I think it's a possibility, though. I think they can actually insert the genes in, and because if it were a static system where if you have the gene, then you always transcribe it and you always make it. That's not the way it works. The system is intelligent. Gosh, if you knew how intelligent your genes were, you would be absolutely amazed. Every one of you would believe in God, just understanding how amazing the genetic material is and what it's doing. It's not just genetic material. Like let's say one of your cells needs a certain protein, sends a signal into the nucleus, and in the nucleus there's a librarian. It's a protein, but there's a librarian there. And so they go to the librarian and say, we need this gene. So the librarian goes, looks up through the card file. Oh, yeah, I know where that is. Let's see, up here, right here. And then it unwinds the DNA, transcribes, and then closes it up, clips the ends on, and hands it to the guy, and they go out and bring it to the outside to the endoplasmic reticulum. And then they look at it and they go, oh, that's not the way we want. We don't want this other one, actually. They break it up and throw it away. And the guy goes back in and says, no, we didn't want that one. We wanted the other one. Oh, that's right. That's over here. That's over here. Okay. Unwinds, transcribes it, sends it out. And they go, oh, yeah, that's the one we wanted, but there's an end missing. Oh, okay. So they break it all up, and the guy goes back in and says, yeah, that's the one, but there's an end missing. So he goes, oh, okay, I know what to do. And the librarian goes in and unwinds, transcribes it again, and then goes to another one and says, and unwinds and transcribes that part, puts it together and says, here's what you're looking for. And then they go, yeah, that's what we wanted.
Wow.
And that's an intelligent system. That's not something that's just random. So when you start putting random genes in, what's going to happen? Well, it depends on where it inserts. And then it has to be able to turn on. And then does the librarian in the nucleus know where that gene is and what it does? And so that when the cell comes in and says, hey, we want you to transcribe some insulin, then it'll go, oh, yeah, we just got that in. And then they go and transcribe it and put it up. I don't know, but it's possible because it's an intelligent system.
That's awesome. So I did use ChatGPT. I said, give me 10 questions to try to stump Dr. Saunders related to diabetes. And this was the first one. And there you go. I mean, we got a great answer.
Well, I had an opinion anyway.
Yeah, right. Yeah. I mean, it is an opinion question. So the second one is interesting to me. It's about metformin. So it's there's controversy about metformin potentially contributing to lactic acidosis and vitamin B12 deficiency. Do you think there's a future alternative that would surpass metformin as the gold standard medication for type 2?
Yes, absolutely. You know, you can do the same thing that metformin does with berberine. And berberine will do what metformin does, but it doesn't have any issues with lactic acidosis, nor does it have any issues with vitamin B12. So you still store your vitamin B12, you still use it properly in the liver. It doesn't mess with vitamin B12. And it tells your body to use fat for energy instead of glucose. And that's essentially what metformin does too. Just works in a different way. So I would say berberine is going to make that difference.
So GLP-1 is like something we're hearing more and more of recently. And just could you help explain what that is? And is metformin connected with that? And is berberine? And how does that all work?
Okay, GLP-1 is glucagon-like peptide, GLP. So glucagon is a hormone that is kind of like the opposite of insulin. Insulin tells your body to that there's a whole bunch of sugar around. Don't use fat for energy. Use glucose. And because you just eat, you make a whole bunch of insulin and you stop making glucagon. When you are not eating, then the insulin drops down and the glucagon goes up. And glucagon tells your liver to put out more glucose. That's part of what it does. It tells it to break down glycogen and put out more glucose. And so these, and it makes you, brings in, allows your cells to bring in more glucose instead of like insulin blocks fat from being used. Glucagon allows more fat to be used for energy. So they have that kind of opposite effect. So metformin has some effect on that, but not on the hormone itself. It just on effect, essentially the same effect of how the cells are using energy or producing the energy from either glucose or fat. So the metformin tends to move the cells to use more fat, and glucagon tends to tell the cells to use more fat. So they kind of do the same thing, but not directly. This just indirectly. They don't work together, for example.
Cool. Interesting. All right. Well, that's all I've got. I'll let Leslie ask more questions. I mean, if you need more, I could probably come up with some, but
No, that
I'm
was
sure
good. That was good. I have some, but if you have some that you want to add, that's okay. All right. So, is this a myth or truth? I will likely develop diabetes because I'm overweight.
Oh, not true. That is really interesting. A lot of people think that, well, you're gaining a lot of weight, therefore you're going to have diabetes. Well, fat doesn't mean you have insulin resistance. I mean, it could, but not necessarily. There are plenty of people who have a lot of fat on their bodies. They're just storing a ton of fat and they have no insulin resistance at all. So you can store fat for a lot of other reasons, just eating a lot. And that doesn't necessarily mean you have insulin resistance. But here's kind of the thing, is that if you're eating a lot of carbohydrates, if you're eating a lot of sweet things, if you're having a lot of things that are artificially sweetened, so sweet, honey, sugar, high fructose corn syrup, fructose anywhere. Gosh, it seems like fructose is kind of the enemy. And it wasn't that long ago, only a few years ago, they were saying, oh, fructose is the best sweetener there is because it's a non-caloric sweetener because it's not glucose. But it still causes you to make a bunch of insulin. It still causes insulin resistance. It still causes fatty liver disease. So fructose is not, they were saying it's a low glycemic sweetener. And yeah, that's true. It's not glucose. It has to be used by the body like fat. It has to be processed by the liver. And that's why it induces fatty liver, people who eat a lot of it. So that if you're having a lot of sweet things, then you're more likely to get insulin resistance, irrespective if you're fat or not. There are plenty of people who are quite thin who have a lot of insulin resistance just because they're eating a whole bunch of artificial sweeteners and sweet things. But they need their latte in the morning has 3,000 calories in it or something like that. But some people don't gain weight and they still have insulin resistance, and some people gain weight and don't get insulin resistance. So it's the weight isn't the issue.
All right. Truth or myth? I eat a lot of sugar, so I'm worried I'll get diabetes.
That's actually a possibility. I just talked about that. And so that's true. Eating a lot of sugar does induce insulin resistance and can lead to diabetes where the blood sugar is actually high. But you know what? The insulin resistance, like we've talked about before, is actually more important. It's more of a problem than high blood sugar. And many people have kidney failure, Alzheimer's disease, they're losing their eyes, their vision, before their blood sugar ever goes up. So that insulin resistance is not a small thing, but it's true. While you are more likely to get type 2 from eating a lot of sugar, it's not always the case.
Okay, so truth or myth here. My provider put me on insulin. This means I'm not doing a good job of managing my blood sugar.
Well, maybe. See, unfortunately, the type 1 and type 2 diabetes illnesses, which are completely opposite from a cellular level, they have the same name. And in having the same name, the doctor treats them the same. As if, with type 2, where you have excessive amounts of insulin. Type 1, you have an insufficient supply of insulin and require insulin very often. And so type 2, you have excessive amounts of insulin, but the doctor still treats it as if it were type 1 and gives you insulin. So that issue doesn't mean you're not controlling it well. In a sense, yes, it means you're not controlling it well, but that's not the issue. The issue is to decrease the intake of glucose, and that would help a whole lot more than adding more insulin.
All right. Truth or myth? It is not safe to exercise with diabetes.
Oh, that's a myth. Okay. And people have said that a lot. People said, oh, it's exercise. You have to be really careful exercising when you have diabetes. No, you don't have to be really careful. You have to exercise. Exercise is so important. Do you know that exercise for your muscles is like a shot of insulin? Because you don't need insulin to get glucose into your muscle cells when you're exercising. When you're exercising, they can suck in glucose, and they're going to require glucagon to be made. So the first weekend of every month, I do 3 days of fasting, and then I usually do my run on. I don't run on Saturdays or Sundays, but on Mondays I do a 5K run. So Monday morning before I have breakfast, I've been fasting for 3 days. So my last meal was Friday. I didn't eat anything on Saturday, anything on Sunday. Friday morning was my last meal. So all day Friday, Saturday, Sunday, I didn't eat. So now we're on Monday morning, and I go for a 5K run. And so do I get hypoglycemic? Yeah, I actually have. I had to stop and walk a couple of times, getting dizzy, because as you're exercising, the muscles bring in glucose as if they had a bunch of insulin, even though there's no insulin there and no food there. So then that's forcing the liver to put out extra glucose, and sometimes that takes a little bit of time. So you can get hypoglycemic by doing it, but that's not a problem. It's actually so much better for you to exercise than to worry about getting a little bit of hypoglycemia.
I gotta go. Bye, everyone. But you're in great hands.
Bye, Joe.
Hi, Joe.
Thank you.
Actually, a question from Joe. Truth or myth? There is not a link between environmental toxins such as microplastics or pesticides and the increasing rates of insulin resistance.
Oh, that's really hard. Okay, so I don't know about the pesticides and microplastics, because how do you ferret out getting all these microplastics and pesticides? So people who are eating non-organic foods and all that stuff, they have more microplastics and they have more pesticides, but they also tend to be eating a lot of processed foods. So they're going to have more glucose, more sugar, more high fructose corn syrup in their foods than people who are eating organic foods, for example, that have less pesticides and microplastics. So yes, I've seen the study where they showed, oh, look, there's the people that are eating, that are getting these more of these microplastics and pesticides, they're eating non-organic foods, they do have higher rates of diabetes. Well, that could be for a totally different reason and have nothing to do with the microplastics. But there was a study in just talking about environmental toxins in Texas. I don't remember exactly. It was a really interesting study. So in a lot of foods, especially like candies and stuff, they use titanium dioxide. Titanium dioxide is like the pure white. It's when you get paints and you have this pure white paint, the white color is titanium dioxide. That's what it is. And it stays white, and it's really white. So it's used as a coloring or as a background to make things so they aren't transparent, so that they're more cloudy, for example. There's a lot of reasons for using this, but it's just for appearance. This titanium dioxide. Well, they found at the University of, I think it was the University of Texas, they found that the titanium gets into the pancreas and does reduce insulin and cause more diabetes, or it can cause more diabetes, but does reduce insulin.
That's so interesting. Now I want to look that up, actually. Yikes. Okay. Let's see, truth or myth. I have borderline diabetes, so I don't need to worry.
Yes, I've heard of that. In fact, doctors have told some of my patients that, oh, it's borderline diabetes. You don't have anything to worry about. You're good. Yeah, just come back to me when it's diabetes.
Yeah.
Okay, so we have that problem in medicine generally, that we have a treatment, but the treatment isn't appropriate until somebody has reached this level, whatever it is. So everything's on a scale, and you have to get to this level. So for example, if someone has a blockage in their artery of 50%, and they're not having any symptoms from it, the doctor will put a catheter in, they'll go into the heart, and they'll say, oh, you have a 50% blockage of your left main artery. That's called the widowmaker. And so we should watch that. When it gets to be about 70 or 80%, or you start getting chest pain, then we can put a stent in, we can do bypass surgery, these are our options. We could do treatment. So let's just watch it until it gets to that point, right? Until it gets to 70%. If someone has a cataract and they're but you have a mild cataract, it's like 20%, it's okay. When it gets to about, like, you can't see very well, like over 50%, maybe 70, 80%, then we'll replace it with a plastic lens. We'll put a new lens in there. That's the way we're trained. And diabetes is the same thing. Oh, you have pre-diabetes, so you don't have anything to worry about. When it gets to be diabetes, then we'll put you on insulin and give you these treatments as drugs or whatever. That's not the right thing. The right thing to do is, where are you on the scale? And if you're getting a little higher, then how do we reverse that? So how do we reverse heart disease? Well, that's one of the things we talk about on this webinar. Reversing heart disease. How do we reverse cataracts? Well, there's actually things you can do. There's eye drops that you can get to reverse cataracts. And when they're early, if you wait till later, it's not going to work. So it's kind of important that you look at things as a scale and not a yes or no question, because the doctor's going to look at it as a yes or no. Either you have it or you don't. If you don't have it, we don't treat it. If you do have it, we do treat it. And here's the cutoff. So no, just change the way you think to, where are you on the scale?
Okay, final question, truth or myth? Once I start taking diabetic medicine, I can never stop.
Oh, yeah, that's a great one because that's a total myth. And that's true with all medicine, blood pressure medicine, cholesterol medicine, thyroid medicine, diabetes medicine, all of these drugs, the doctors, we are not taught in medical school how to get people off of medications. There's just no schooling in that at all. So the assumption is if you're going to start a medication, that's for life. You're never getting off it. Why? Because I don't know how to get you off it. I don't know how to. I don't know what else to do. So there's no other option. So that's all you could do for the rest of your life. So with diabetes, no, you know what? It is so easy to reverse that. And the diabetes solution kit, just going through that kit and going one by one, I'm going to do this, this, this. And then as your glucose, your blood glucose is dropping down, your hemoglobin A1C is getting into the normal range. And then you're going back to your doctor and saying, hey, you know what? I'm doing so much better. I'm a little worried about hypoglycemia. Which medication should I stop first? And then you just gradually, with your doctor's help, get off the medications. And we've had tons of people do it. Tons.
Mm-hmm.
Thousands,
yeah,
right?
Comment if that's one of you or if you're watching and that's happened to you. We love to know that. Okay. I'm going to go into some questions. So if you can post your questions in the Q&A, that would be wonderful. Just easier for us to manage them there. All right. Let me see here. Alice says, after 7 months on Cinechroma and turmeric, my blood glucose still doesn't drop below 100. Why would this be? And what may be interfering? Medications, stress, etc. Oh, there's a lot in that question.
Yeah, there is a lot in that question. Okay, so let's start with the Cinechroma turmeric. Those are helpers, and they really aren't things that are going to drop your blood sugar into the normal range. Your glucose is going to go down when you're on phase 1 of the program. So the program is the diabetes solution kit, and you're doing a phase 1. And in phase 1, you are getting off of all carbohydrates. Well, not all. Of course, you get some carbohydrates, but you're getting off carbohydrates so that your body can use up all the stores of glucose. It's called glycogen. You're going to take it all out of your body, and then you're going to start burning fat for energy, and the insulin is going to go down, the glucagon is going to go up, and all of these are going to start balancing. But that's not done from the Cinechroma and the turmeric. The Cinechroma and turmeric help. Well, the turmeric helps get rid of inflammation, which contributes to insulin resistance. And then the Cinechroma is to help with deficiencies that are fairly common deficiencies that can contribute to insulin resistance as well. And so those are contributing factors. And the purpose for the supplements is to make it easier for phase 1 to work. So if you have, let's just say you have chromium deficiency, and you have type 2 diabetes, and you go on to phase 1 of the program, and you're doing it really well, and you're making ketones, but your blood sugar's still over 100, and you're like, what the heck? What's going on here? Why isn't it going down? It's because you're deficient in chromium. So then you add the Cinechroma, and all of a sudden everything comes to normal again. But the Cinechroma is the answer for deficiencies. For excess, the answer is to decrease it. So detoxing is really the method to do that. So that might be why. And the indication, though, that if your morning blood glucose is over 100, then you're still insulin resistant. So the question then is why? Is it because you're deficient in chromium? Is it because you're still eating carbohydrates and you haven't depleted your body of glycogen? Or is it some other reason? Inflammation, stress. Remember, we talked about stress. So we've had people on this program also that have told us about how stress affects their morning cortisol.
Okay. Anonymous says, I understand that not all olive oils are equal. How does one differentiate between good ones and the not so good ones?
I don't know, that. Thank you for asking that. That's interesting. I read an article in Consumer Reports about olive oils. And what was really amazing was that even these really expensive imported Italian olive oils were 40 to 60% canola oil and only 40 to 60% olive oil. And so they deodorize the oil sometimes by putting in a lot of canola oil and just having a little olive oil. So there is some olive oil in there. And yeah, so and they're not, canola oil is really not a good oil. It's not like olive oil. Olive oil is omega-9 and it doesn't oxidize very much, and you can cook with it, whereas canola oil you should not cook with. It has too many omega-3 oils in it. Omega-6, I'm sorry, not much omega-3. It has a lot of omega-6, which in high heat they become trans fats. So the pure olive oils, and gosh, I wish I could remember what the two of them were, but one of them was an imported Italian one that was actually really good. It was 100% olive oil. And the other one was the Costco Kirkland brand. And those were the two that were 100% olive oil. And all of the rest of them were diluted with some other oil.
Wow, interesting.
Yeah, isn't that weird?
It's good to know. Okay. Let's see. Anonymous says, I had a doctor appointment Monday, and the doctor wants me to discontinue my insulin and start Ozempic. I know Dr. Saunders has mentioned this before, and he's not too keen on Ozempic, so I'm at a crossroads. What do I do?
Well, I don't know your whole situation on what you do, but let me give some general principles about what does somebody do about that. The peptide injections can be helpful for some people. I've had people lose weight on peptide injections. I've had 3 people do peptides. One of them, it didn't work at all. One of them, it worked temporarily, and then she gained it all back again. And then the other one lost weight and did pretty well on it. So it's not that it's always bad. It's kind of like insulin. It's not always bad. I have a patient on insulin currently, and she has type 1 diabetes. She needs insulin. We're trying to get her off insulin, but it may be a while. So the principle is, does that apply to me? Is there a better way to do this? Is there a way out of this? So if your doctor says instead of insulin, use Ozempic, that means you must have a pancreas that's making insulin. So you don't have type 1, you have type 2. And if you're insulin resistant and you're making a lot of insulin, the Ozempic is not a good idea, because that makes you produce more insulin. That's how it makes your blood glucose go down. And by doing that, it makes you more insulin resistant over time. So that's why people who go off it gain the weight back. And so they're told, oh, if you go on Ozempic, you're on it for life. Because if you ever go off it, you're going to balloon out like crazy and get diabetes again. Well, yeah, that's because it's making you more and more insulin resistant. So, if your pancreas is putting out a lot of insulin, it's so much better to not add anything. No drugs, no medicines, no supplements, no foods, nothing. Just take it away. Take away everything. Just eat nothing, drink water, fast. Whatever it takes, just eat salads every day. Just take away everything that you're currently putting in your mouth. That's the solution if you have high insulin levels. It's really, the medications are invariably more harm than good.
All right. Wayne said, after about 2 months, I'm starting to see a decrease in my blood sugar readings. After a meal, my glucose has on average decreased from 120 to 130. Was 120 to 130. Readings are now 100 to 110. My morning fasting glucose is 130 to 140. down from 140 to 170. If my glucose does eventually get to normal levels, will I still need to monitor my glucose?
Oh, that's a good question. Um, I would occasionally, at least, every once in a while, because again, where are you on the scale? And so you're up here on the scale, and you're going down, and then when you get to normal, do you have to monitor it? No, you don't have to monitor it every day. But if every once in a while you check it, I don't know, every few months or whatever, you check it, and you say, oh, I'm back up here on the scale. You know what to do to bring it back down. So yeah, but at least occasionally, I think it would be a good idea to check it. And if that only means, your annual exam or something like that to check your hemoglobin A1C, that's reasonable too.
Okay. Tom says, can you talk about how the body uses water? Last week you said someone who drinks a gallon of water a day could not do a dry fast, but or they will get dehydrated. But if someone only drinks a quart of water a day, they can do a dry fast.
Okay, that sounds almost paradoxical, doesn't it? Okay, so the kidneys have the ability to concentrate urine to hold on to water in the body. And if you don't have a good concentration gradient in the kidneys, if your concentration gradient is narrow, then you can't concentrate more water more than that, because it's called an osmotic gradient, and you have a certain amount of solute that sucks the water out of the urine, and then it's reabsorbed on the other side. And if you don't have the ability to concentrate the urine to get the water out of the urine, then it's going to spill into the urine. The urine's just going to go. So people who drink a gallon of water a day, they have a very narrow osmotic gradient in their kidneys. So they can't concentrate urine, and they need a wide osmotic gradient to where they can take all the water out. So you're peeing out mud, essentially. That's all that's left, because you can suck all the water out of the urine, and keep all of the junk that you don't want, all the nitrogen wastes and all that, all the whatever the yellow stuff is, so that you have this really dark yellow, almost brown urine, because you can take all the water out. Whereas if you're peeing white all the time, that's what they tell you should pee white all the time, you don't have enough concentration gradient. So at night, when you lay down, you make a hormone called antidiuretic hormone. And that hormone tells your kidneys, hey, just concentrate all the urine so I can sleep all night, so I don't have to get up to pee, not even once. But what if your kidneys can't do that? What if you have a very narrow concentration gradient? What if your osmotic gradient is very narrow and you can't concentrate? So what happens? Well, you're peeing out a bunch of water. Even if you didn't drink any, it doesn't matter. The kidney can't concentrate. You become dehydrated because you don't have enough, you can't concentrate your urine. So you have to drink more water to keep up with it. So drinking more water causes the need to drink more water. Now let's go to the other side. Let's say you're only drinking a quart of water a day and you're a little dehydrated. Your kidneys are going, oh my gosh, we got to hold on to water. So now you get a very wide concentration gradient, and you suck all the water out of the urine, so that the urine that's being excreted out into the bladder is very concentrated, and you're holding on to all that water because you have a really good concentration gradient. That's the difference. So that's what I meant by that. So you can't take somebody with a really narrow concentration who's used to drinking, a gallon of water a day, and say, oh, you should do a dry fast for 3 days. No, because their kidney can't handle it. The kidney can't concentrate the urine, so they're just going to be losing water. They're going to shrivel up like a prune.
All right. Okay, next question. Let me see here. David said in Colombia, there's a health service which covers almost all, I'm like reading words that aren't there, which covers almost the whole population. But when I have used it, or my wife has, the average visit time is 5 to 10 minutes. There are more advanced elite health plans, more expensive, but even then the visit time isn't much greater. So we'd kind of asked that earlier, if you guys could let
Yeah.
us know how much time you get to spend with your doctor in the office.
Yeah. Interesting. So I wonder in Colombia, they probably have a pretty good health system then if it covers almost everybody. And 5 to 10 minutes, yeah, that's kind of probably average.
All right. Anonymous says that diabetic family member suggested I eat protein before going to bed to counteract the glucose dawn phenomenon. Is this advisable, as I'm trying to have my last meal by 6?
No, it's not advisable. It's a lot more important to become anabolic and avoid putting any food or anything in your stomach. You need an empty stomach to make ghrelin, and that hunger hormone is really important for repairing your body. So yeah, forget about the dawn effect. That's all that is signifying that you have some insulin resistance. And so adding the protein in to counteract the effect, that's like putting a Band-Aid over it. It's not really the answer. The answer is to not have insulin resistance. And you do that by doing, well, phase 1 of the program.
And if you are not familiar with phase 1, go to bartonwebinar.com. You'll find a link to the diabetes solution kit. That's what we're talking about. It's the book where you do 3 different phases, and it has worked for so many of you on this webinar. If you're one of them, comment and let us know so we can tell people, you can tell people how it worked for you. That would be great. Okay. Let's see. Did I do that one? Anonymous said, if you have diabetic neuropathy and you've had it for years, will the Nervala work, and how long do I need to take it to get results? And at $100 a month for 2 a day, I can't afford it. Any other suggestions? That is with the 25% off. Thank you.
Okay. The question of will it work? There's no guarantees in life, in anything. You know what? Here's the reality of life. Just so that everybody knows. When you're getting into something, you don't know what you're getting into. When you start anything, you don't know what you're getting into. That's why we have promises and commitments and covenants. When you get married, you don't know what you're getting into. When you have a baby, you don't know what you're getting into. When you move to a new location, you don't know what you're getting into. When you start college, you don't know what you're getting into. So you're starting a program. You have this issue. You have diabetes. You have neuropathy. That's a problem. What is your goal? Your goal is you want to not have neuropathy. You want to have normal feeling in your feet, and you want to have normal blood glucose, and you want to have insulin sensitivity, so normal insulin sensitivity. So you take those goals and you say, what is going to get me to those goals? To have normal insulin sensitivity, normal blood glucose, and normal feeling in my feet. And so you look at all the options and you go, well, that metformin's probably not going to work. Those drugs probably aren't going to work. The neurologist gave me this gabapentin or whatever they use, and that's not going to make me better over time. So what has a chance of making me? And you do all the research and everything, and you come out, hey, look, alpha lipoic acid is something that has been proven to reverse diabetic neuropathy. And benfotiamine is another one that has been proven to reverse neuropathy and diabetes. So those are things that I would be willing to try. That's fine, and you can look up to try and find a less expensive one. You can look up online and go, okay. Alpha lipoic acid, how can I get this much? Because remember, we have the right amount in there, and so look at that as that's the amount you want. And so I haven't found any that have both of those in there without a bunch of other junk in it and in the right amounts. So look it up, find alpha lipoic acid, see if you can get that somewhere. Get it from a reputable place, because there's a whole lot of crazy supplements out there that they're unregulated. Nobody knows what's in them. So, you know, I know when my dad had diabetic neuropathy, I put him on Nervala. I had the auto ship. It was going to him every month because, and I paid for it because I don't get any break just because I work for Martin Publishing. So, and the reason is because I know where it's coming from, and I've been to the place that makes it. I've been to the suppliers of where it comes from, and so and the other things after so many experiences of Amazon selling anything to anyone without any regulation at all, I'm like, well, you just don't know what you're getting. So you can try and get it from a reputable place. Look for alpha lipoic acid, look for benfotiamine, get the right amounts, and try getting those. And that it may cost you less.
I was just thinking we should find the pictures of us at the facility that we toured and post those in our Barton webinar group so you guys can see. I mean, it was a really neat facility.
Yeah.
Okay, let me see here. Are there any low calorie sweeteners that are good for you?
No. I was talking about fructose earlier. Fructose is not good for you. But even like stevia, not good for you. Monk fruit, not good for you. All the artificial sweeteners that are alcohol, sugar alcohols, they're not good for you either.
All right, let's see here. Don says if I do strength training while fasting, I can lose muscle when I run out of glucose.
Oh, good question. Good question. So the question is, am I going to lose muscle mass if I'm fasting? And the answer to that question is yes and no. When you're fasting, so long-term fast, Dr. Valter Longo's done a lot of research on this, and I went to one of his lectures and he explained this whole situation of how it works. So your body starts using protein to make glucose. It's called gluconeogenesis. And that protein, where does it come from? Well, it comes from muscles, but it also comes from a lot of the extra amyloid proteins and plaques and things that are just waste in the body. And that's called autophagy. What's really interesting, though, is if you're fasting, you lose a certain amount of muscle mass. Protein mass is what Dr. Longo put it on. And then after you're done fasting, you gain it back first before you gain any fat, plus more. So you actually improve your muscle mass over time. Now, if you're working out, your body will not use the proteins that are being used. So your body will take proteins that are not being used. So senescent cells and cancer cells and dead cells and amyloid plaques and other plaques, tau proteins, and all those things in the body that are not being used will be used up first, and your muscles won't be used. That's why it's important to exercise while you're fasting.
Truth or myth? We have one from Kimberly. If you're a diabetic, you need to see an ophthalmologist instead of an optometrist.
Well, yeah, technically. So the ophthalmologist is a medical doctor who's a specialist in the eyeball. An optometrist is a doctor of the eyeball. And technically the optometrist is a doctor of the refraction of the eyeball. So it's glasses, right? It's how well you see. And that's an entirely different thing from the ophthalmologist, which also can look at how you see, is the refraction of the eyeball, but will also look at diseases of the eyeball. Well, these days, optometrists are pretty well versed in looking at a retina, for example, and being able to see, oh yeah, you've got some diabetic retinopathy, and you should go see an ophthalmologist. Often they'll do that. You should go see an ophthalmologist. But yeah, they can point it out from an optometrist. But yeah, so classically, the optometrist was just for glasses, but essentially, they're pretty well trained in either one.
So another question here from Michelle, what drops help reverse cataracts?
Oh, yeah, that's called carnosine, and the brand name is Can-C, CAN-C.
Okay.
Can-C eye drops are have been around for quite a long time. They do pretty well for decreasing inflammation of the eye and getting rid of early cataracts. Yeah.
Okay, Anonymous said, my recent A1C, 8.3. My diet does not include fruit, sugar, sweets, or natural sweets. I've eliminated grains from my diet, but did a low carb, 1 to 2 grams with 11 grams of fiber per serving, wheat bread. Metformin does not work for me. Still not able to get glucose level to normal. It's always above 125 unless I do a 3-day fast. I use your supplements as well.
Okay. It sounds like you may have an insulin problem. So if you're eating that little carbohydrate and still getting blood glucose over 120 all the time, with a hemoglobin A1C of 8, that means your average blood glucose is 200. So when you're eating, it's shooting way up, which means you're probably not making enough insulin. So the next test to do is do all 4 tests at once: hemoglobin A1C, glucose, a C-peptide, and an insulin level. And the insulin level tells you what that is at that second. The C-peptide is more long-term, over like the day. And and the C-peptide distinguishes it from any other insulin external, like if you're injecting insulin or something. The C-peptide is it tells you what the pancreas is making. So that'll tell you your pancreas function. That may be an issue. And if that comes up, that you have some insulin, but you're not sure if it's enough, then do a 3-hour glucose tolerance test with insulin. So you measure the insulin before or fasting. You measure insulin and glucose, and then you drink this terrible syrup, glucose syrup. And then it's not terrible, it's sweet. It's actually okay. And then you test the glucose, insulin every hour after that for 3 hours. And that gives you a what happens to your glucose and what happens to your insulin. Because I've had people have normal insulin, and then they get the syrup and their insulin shoots way up into the hundreds. And their glucose goes way down into hypoglycemia. And I've had it the other way, where the insulin doesn't barely go up at all, and the glucose shoots way up into the stratosphere. So,
all right. Okay, we are past time.
Past time, overtime.
So
Hey,
we'll see you tomorrow.
I don't even get paid for overtime. What is this?
I know, right? Okay. Well, you were on tomorrow's webinar already, so.
Okay.
Bye. All right. You can find more information at bartonwebinar.com. Use code webinar25. That's one word to save 25% on anything that you may want to purchase there. But come back tomorrow. If you haven't registered for tomorrow's webinar, you can find that at Barton Webinar as well. But we look forward to chatting with you soon. Thank you for hanging out with us. Sorry we couldn't get to all of these questions.